I have to confess, I can't really answer this completely. When, why, and how do patients change in psychological treatments? But I will try to give you like a little bit an idea on the newest research developments in that area. And I would like to start with a little task I usually give to my students when I teach research methods in our clinical training program. That's the task with the question: imagine you finished your clinical training program and you work already a few years. How good are you as a therapist in relation to all the other therapists? Rate yourself in a position to all the others from a scale from 0 to 100, and 0 would be the weakest therapist and 100 would be the best therapist. You might can imagine what usually comes out of this, that most students see themselves in the future somewhere above the 50th percentile. And there have been actually studies done on this, and that shows the same. We all tend to overestimate ourselves, being more, nobody does say I'm below average. And that's really a natural kind of phenomenon. I mean, we have that 93% of us think we are above average drivers. That's the same thing for engineers. That's actually a good thing. But it also shows you that our individual perception, I mean, is a little bit biased. And it makes sense to look actually what's going on. And we did this in the field, like with this kind of data where I combined like data I used for the last 20 years with about 50,000 patients, 8 data sets from 3 countries, and with over 1,800 therapists. And that's actually what you get. You get a distribution. There is a therapist effect. There are differences between therapists. I will later talk a little bit more on this study in the workshop, which follows in the afternoon. But when you look at it, most of the therapists, there's a distribution around the 50% level on average, but there is, at the borders, there are most effective ones, which is about, they're significantly better than the others, with about 17%, and about 16% of therapists doing weaker than the others. And the overall effect size of therapists is about 0.54. So there is an influence. So I'm coming back now to the statement I want to make. I think it makes sense to use psychometric assessments and feedback of psychological change. That should be part of clinical practice in order to support the delivery of psychological interventions. So treatment tracking and feeding back the psychometric information, that's an important issue. And we can use modern tools developed in the context of e-mental health and feedback research in order to realize this on a daily practice level. But the decision on the clinical validity of that information has to stay in the hands of a scientifically well-trained therapist. And the other thing, it's also something I will probably talk more about in the afternoon in the workshop, is we have to deal with a lot of variation in different settings. So several data sets could be used for validation. We have to deal with a large patient and setting variation. So that's more a statistical point which comes up in the workshop later. So in order to do this, so we developed a research program at the University of Trier, which follows at 3 levels. It's basically a research program on how people change through psychological interventions, and it's focusing on a macro, a meso, and a micro level of change. So the macro level of change, that's more on the services research level with thousands of cases and large insurance companies' databases, for example, where we look to feedback into practice, try to predict the course of change. The meso level goes a little bit deeper down on individual change patterns, until also individual videotaped sessions, and to see what's influencing like change on that level. And the micro level, I'm not talking too much about this today, and because I think there are speakers more focusing on that level. That's the level where you really dig out like a specific intervention like a 1-hour intervention, manualizing it, and to see if that makes a difference if you're studying it also maybe on a psychobiological level, so on different. So we have coming from a services research level with thousands of cases to like small-scale studies looking on a micro level of change. And all this is hooked up into an outpatient clinical program and research setup in outpatient center and at our university, where each patient basically progress is tracked over the course of treatment, and you see a little bit the electronic setup or the whole setup of this here. Like we have touchscreen data entry for the patients, so that's very easy to do, and there's like a portal for each therapist, so they have access to see the progress for each of their clients over the course of treatment. They get signals if a patient isn't progressing as well as expected. It's here like a green light, and if every session is videotaped and is part of the research program in a way. I will come a little bit back to this later as well as in the workshop. Now, a little bit smaller set of this kind of setup was also used in a study we did in several areas all over Germany, where also such a feedback system was used to support the decisions if treatment should be provided or not provided at the beginning, or funded by insurance companies or not, or treatment should be extended, or that more sessions should be done with that patient, because usually that's done in Germany based on a written report, and then somebody from the insurance companies, a reviewer, does decide if there will be this therapy will be funded or not. And this was supported basically by additional psychometric information within that study. It was done in, as I said, in 3 areas of Germany, and we had about 1,000 cases with that, where that psychometric information was given, and about 600 cases were in the control group. We had several comparison groups in other areas, but we didn't have psychometric information, only socio-demographic information on those. And what you see here is basically in about 70% of the cases, therapists use that psychometric information. They factor this in their clinical decision, like the progress information, like those charts about progress which I showed you before. They use that information for their decision, and only in about 30% they did no modifications based on it, which is a high percentage. If you imagine, if patients make progress as expected, you wouldn't need such an information. It's mostly important if they don't make progress. So the therapists use that information, and it's interesting what they do with it. So for example, it's especially important to discuss this information with their patients, especially if they do not, if the patient does not make progress or does make a negative change. So the therapists discuss it, the information with the patients. They use it to adjust their interventions, especially here again, when the red, that means that there's a deterioration, patient is already on the deterioration path like this, or there's no change, like that's the blue line, the blue barrow. And it's the same thing, they try to work on their therapeutic alliance, especially if there's no change happening up to this in the first 10 sessions. So it's actually used. And here what you see is the reaction of the patients. And you see that the patients on a very high rate, they like this idea of tracking patient progress, on monitoring the quality of outpatient psychotherapy. I find it important to monitor the results of therapeutic treatments. So over 90% basically agree with that kind of statement. So patients are positive related to it. And if you look to the effects, there's some kind of a differential effect here that you can see here. It depends on the attitudes of the therapist related to it. So patients are very positive, but therapists have like different kinds of attitudes toward tracking progress. And that's what you actually see here. If you look to those, how satisfied are you with those quality monitoring aspects and the aspect amount of modifications due to feedback. So if therapists are not satisfied at all here, so they don't like this idea of tracking progress psychometrically, but they do a lot of stuff based on the feedback, like to do several modifications. So that's a bad sign, usually. They have really negative, or they have very low effect sizes at the end. But if they are positive, and they do just one specific modification, if they are specific, then they have the highest effect sizes, basically. So it depends on the attitudes of the therapist, the effects of that psychometric feedback. And as I showed you at the beginning, you can also look to therapist effects. So this shows you the distribution of the therapist effects within that study. We had overall about an effect size of 9.8%. 9.8% was the therapist effect in explained variance, which is about an effect size of 0.66 in that study. And what you also see here is a relationship of the therapist effect related to initial impairment. So this shows you here, it's also a study done by Dave Saxon and Michael Barkham in the UK using a huge database of IAP data. They found the similar kind of results as we did here within that German study. A relationship between the initial symptoms severity and the therapist effect. So if patients are not very highly disturbed at the beginning, the impact of the therapist is relatively low. It's 0.08 in terms of effect sizes. But if the patient is very highly impaired, you see this relationship, then the effect size of the therapist is 1.58. So it's the impact. The more disturbed patients are, as more important is the role of the therapist, given the results of that study. Now, once you do this, you look to the individual effect size of therapists. You can dig those out where you have enough patients per therapist, and we do studies using those large databases to calculate when would you say this is enough cases per therapist. But to calculate individual effect sizes based on outcome, so you have the effect size for each. This represents one therapist, each one therapist, the effect size related to outcome, related to dropout. So there are differences in dropouts between therapists as well, and there are differences in treatment length. Now what you see here in this is, and the larger effect size means better outcome, less dropout, and shorter treatments. Now this is something like a super shrink, for example. He has a very high individual effect size, a low dropout rate, and relatively short treatments. There's no overall correlation between the effect sizes in outcome, in treatment length, and dropout. But you can basically see that's a case where there's a negative effect size for the therapist, very long treatments, and a high dropout rate. Whereas here for this, which is interesting, those cases are interesting in a way, so they have high effect sizes in outcome, longer treatment length, but they have high dropout rates, which is interesting. That's probably therapists which search for cases in a way. They basically treat those where they are successful. The others probably don't stay in those kind of treatments with them. So it's a way to look individually on differences between therapists related to effect sizes in dropout, treatment length, as well as outcome. Now I jump a little bit to another way to look at this kind of data, and that's used to predict the course of treatment. And here to develop differential predictions or personalized predictions I think that's a topic which will come up in the future, uh, um, in future research way more often. And we just started to develop this, looking a little bit on back to my time I worked at the University of Bern in Switzerland, looking how do they predict in Switzerland the avalanches. And how they do this, they usually use all kinds of information for a mountain over a period of time, like how wet the snow is, how much snow there is, how long it's around, how icy the snow is. They use all those parameters, and when there's a new day comes along within that area, they select the closest days in terms of those parameters and estimate basically if there was an avalanche in those closest days or not. And if there was in the closest 10 days an avalanche, there would be like a red light here, a red sign for this mountain area. And if there was only in 7 out of those 10, it would be there would be like an avalanche, it would be red. Or if there would be none, it would be white. There would be no warning. And we use, of course, not this kind of information of snow depth and stuff. We used, of course, psychrometric information on the impairment, on interpersonal problems, and the diagnosis to do differential predictions based on the nearest neighbors of already treated patients in different treatment approaches. Now, what's done here is in a study with 600 patients, and they have been treated manual-based at the University of Bochum in Germany with a cognitive behavioral approach and a more integrated cognitive behavioral interpersonal approach at the University of Bern. And we used basically for each case an individualized prediction idea. So here you see, for example, a target case, and that's all of the closest already treated cases. And we use that information to predict the course of treatment for that specific target case with that kind of treatment see here, there would be another target case. You see you select always the closest cases to do the prediction for that case. Now we work on different algorithms to do that. And that's what you get then that way. You have basically an individualized prediction at the beginning of treatment for CBT or this integrative treatment, and they can be different. And you can use that basically to track progress or to make differential decisions between treatment approaches. You see here a different version of this kind of prediction model where the manualized, more problem-solving approach had a better prediction and the case was treated that way. We can also use that information if patients already changed to adapt basically those predictions. And we use all that basically to do prediction models over the course of treatment. So if somebody falls, say for example, between session 2 and 8, one time in the negative below that prediction boundaries, the confidence bound around that prediction model, one time, then the success rate is really, or the probability for no change or failure is about 40%. But if they fall in that range between 2 and 8 sessions 3 times, so the probability for no change, it's above 70%. And vice versa, if they, in a positive way, they do better than expected. So you see, if they're 3 times better than expected, the probability for success is extremely high. It's above 70%. So we use that kind of information basically also in our feedback system to give feedback if the patient makes progress or does not make progress. And we use all of that kind of nearest neighbor idea as an option for the therapist to select for those therapists who have treated already similar kind of clients. So you press a button here in that feedback system, and then there's an R software running in the back, selecting out of the database those therapists who have treated similar clients. And then the trainees can talk to those colleagues having experience already with those kind of similar kind of clients. So basically the idea is to use all that information of already treated patients to make use of that information for the treatment of future patients. Related to that is now here on a more meso level, the research on patterns of change over the course of treatment. So we studied not only the assumption of that we have a similar change pattern for all patients, but having different change patterns early in treatment, and to see if that makes a difference in predicting the course of treatment. And there's one, no matter if it's RCTs or naturalistic data set, there's one pattern which constantly seems to show up, and that's the early response pattern. You see this here in the study on, in the TDCRP study on depression. We have this early response pattern. We have done this with Dave Barlow's data on panic disorders, just published this recently, where you have also this early response pattern. And you have where people just, it's kind of flying into health group, people just come into treatment, and once they're there, seem to be at the right place at the right time, and they really make really fast progress. And you see, this is, for example, if you look to those early responders in the first a few sessions, about 93% of those, they end up being successful at the end of treatment. Whereas those early deteriorators here, so they have no reliable improvement also at the end of treatment. And there is a higher probability that they drop out of treatment too. So I come up what we know already about those early responders. They seem to happen in different settings and diagnosis. The early response group has high treatment effects. It seems they are higher in RCTs than in naturalistic settings. And in naturalistic studies are those with shorter treatments. In RCTs, it's a higher probability for those which finished treatment. And we have still to focus a little bit if there are different rates in different diagnostic groups. It's not too much known on this so far. So I come to the conclusions. I think therapeutic effects exist in clinical practice for treatment outcome and treatment length and dropout. The influence of the treatment of the therapy seems to be more important as more important patients are. Psychometric assessments and feedback should or could be part of clinical routine. It's especially helpful if there's early negative signs for no change or negative change. Patients have a positive attitude to it. It especially works well if therapists have also a positive attitude and do specifically respond to it. There seems to be early response cases. We need more information on those patterns of change, or early in change, to use that information to predict or to do differential predictions in different treatment approaches. And that means so more research on inter-individual differences over the course of treatment seems to be necessary. I think I will go more into details on this in this workshop in the afternoon. That's it. Thank you.
If we go to the basic, maybe a basic simplistic statement, but I think it's fair to say that as psychologists, we want to predict, influence, and understand the way that people respond in certain situations. So if you're a colleague in the US and you want to come to this conference, you're faced with a situation where you have to take an airplane, and some people, when faced with that situation, will basically avoid taking the airplane and not come here. Other people, some of amongst you, have taken the airplane, have come here, and our task is to understand, predict, and influence how people will react in those situations. Now, cognitive psychologists have invented this wonderful thing called the black box. And they say that the way that we react to situations is not due to the situation itself, but to our beliefs about the situation. All kinds of mental representations and mental processes determine how we will respond. So in order to predict influence and understand, we need to predict influence and understand the mental representations and processes in the black box. Now, if we look at clinical psychology, there are cognitive theories of psychopathology who basically say that psychopathology is due to all kinds of dysfunctional beliefs and dysfunctional processes. So people might believe that airplanes will crash or that they will get a panic attack, that they also have all kinds of dysfunctional processes. They pay attention to their bodily symptoms, bodily feelings when in an airplane and so on. And so these things interact. And people will then basically want to capture these beliefs and processes. And that's where my story comes in, basically. I will talk today about measuring dysfunctional beliefs, not so much about the processes, so attentional bias and memory bias and interpretation bias. There is a lot of work on these things, but I cannot cover all of them, so I will focus on the research on capturing dysfunctional beliefs. Now, normally, if a psychologist wants to capture these beliefs and representations, one popular way is simply to ask people. So how much, for example, do you fear flying on a scale from 1 to 7 or something like that? Or how much do you like or dislike spiders? Now, this, of course, we all know has limitations. First of all, it assumes that people know what the representations are that mediate their behavior, which is not always the case. Second of all, is that they might lie about it, or they might feel pressure not to report these representations and beliefs. And then in the mid-90s, social psychologists came up with an alternative type of measure, and they called it implicit measures. Now, what I want to do today is basically try to explain briefly what it is to say that a measure is implicit. So what are these implicit measures, and why is it interesting to use them also within the context of clinical psychology? If you want to know more about it, immediately after the session there is a workshop where I give a more hands-on explanation about or introduction to these measures. So, just one example of an implicit measure so that you know what kind of things I will be talking about. I will, during the workshop, give demos of more implicit measures. But without any doubt, the most popular one and the most well-known implicit measure is the implicit association test. I looked it up before the meeting, has been cited 2,900 times, this paper in which the IIT was introduced, which is quite impressive if you know that the modal number of citations in psychology is probably 0. So it's quite popular measure, and the basic idea is very simple. You have 4 categories of stimuli, but only 2 responses. So if you have 4 categories that need to be mapped onto 2 responses, you have to combine them. So 2 have to be assigned to one response, 2 others have to be assigned to another response. Now, there is the trick, because the way you combine these categories influences how well you perform. If you assign categories which are somehow related for people, if you assign them to the same response, people will like this, they will respond quickly. So for example, you might give 2 tasks, and in one task you have positive words, pictures related to flying, so airplanes. You have negative words and pictures related to not flying, other modes of transportation like a bike, a car, a train, and so on. And in the first task, you have to press a left key whenever you see a positive word or a picture of related to flying, and you have to press a right key if you see a negative word or a picture related not to flying. In that case, if you like flying, then that should be an easy task, because positive and flying are related to you, so they are assigned to the same response, so you should be quick to that. If, however, you dislike flying, you would find the second task easier, because in that task, negative words are assigned to the same key as flying objects, so that would be easy for you if you dislike flying. So the basic gist of this measure is basically you're given a speeded reaction time task, and your beliefs and attitudes and your mental representations are inferred from how quickly you respond in different combinations, in different types of tasks. That's one example of the, in this case, the most popular implicit measure. Now there are many others. I just listed a few here, but all of these things that I've put here on the screen have been labeled with the term implicit measure. They have been used in a lot of areas, so they have been introduced mainly within social psychology, but meanwhile they have also been used in clinical psychology, addiction research, personality psychology, and so on. So many areas of psychology and even outside of psychology. But still, it is unclear what it is to say that a measure is implicit. We all use measures, but what is so special about this class of measures that I'm talking about today, these implicit measures? Many people give quite unsatisfactory definitions. They say, well, it's an implicit measure because the word implicit is in the name of the measure. Yeah, okay, that's not a very satisfying answer. Or they say whenever it's not a self-assessment task or when it's based on reaction times, then it's implicit. But this is not a really satisfying definition. So some years ago, I set out to come up with a more elaborate, let's say, or fundamental definition. And I went back to thinking, what are measures? And measure you can understand in two ways. You can understand it as a measurement procedure or a measurement outcome. As a measurement procedure, basically it's something that you do as a researcher. For example, if I want to weigh somebody, determine the weight of somebody, I can put that person on a weighing scale and read out the number that appears on the screen of the weighing scale. This is a procedure. It's simply what you do as a researcher. Likewise, in an IAT, I can present people with a program, and people then are instructed to give certain responses, and I analyze these responses in a certain way. Again, this is a procedure. It's a list of steps that you do as a researcher. There's nothing implicit about procedures. So it doesn't make sense to say that implicit measures are some kind of special measurement procedures, because procedures are not implicit, they're simply lists of what you do. So probably it makes more sense to talk about implicit measures as measurement outcomes. What are measurement outcomes? Basically, it's the thing that is produced by your measurement procedure. So you put a person on a weighing scale, you see the number appearing on the weighing scale, and this number is the measurement outcome. So you can say that the measure is the outcome of the measurement procedure. Likewise, in the IAT effect, you do an IAT procedure and you get an IAT score, a difference in reaction time between the two tasks of an IAT, and this score can be called a measure. Now, if you say that an outcome is a measure, you basically also say that it's a measure of something. There is some construct that it is supposed to capture. And this idea was really formulated very clearly by somebody who works here in Amsterdam, namely Danny Borsboom, who has a wonderful paper on measurement validity in Psychological Bulletin. And he says that a test is valid for measuring an attribute if and only if the attribute exists, and if variations in the attribute causally produce variations in the outcome of the measurement procedure. What does this mean? So measuring is applying a procedure to a person, and this person that produces an outcome. Now the outcome is a measure if you assume that it reflects something, some property of the person. Okay, so you make a backward inference from the outcome to some property of the person. For example, the weighing scale number, the weight of a person, it tells you something about the physical properties of the person. Now, what Danny Borsboom realized is that this only makes sense, you can only do this, if there are some processes by which the attribute in the person causes the change in the outcome. So the outcome can only reflect an attribute if that attribute exists and if that attribute causes a change in the outcome. That's pure logic. So a real measure, and that's important, if you say that something is a measure of weight, you assume that there is something like physical weight and that there is a particular way in which that weight produces the number on the weighing scale, right? Now, this is also the case for implicit measures, because implicit measures are also measures. You use the outcome of an IAT in order to make an inference about some mental representation within the individual. For example, if you have an IIT about fear for flying or attitudes towards flying, you use the IIT score to infer something about the attitude towards flying in the person. But this can only happen if the attitude somehow exists within the person and if it influences the outcome. Again, this means that your implicit measure has to be a measure. You're making these assumptions when you say that it is a measure. The only thing you need to add when you say that the measure is implicit is to say that the processes by which the attribute in the person produces the outcome, that those processes are automatic in a certain sense. So the representation within the individual automatically causes the outcome. And that is then an implicit measure. So what is automatic? Automatic means that the representation causes the outcome even if people don't have the goal to reveal their attitudes, for example, or even when the attitudes or representations influence the outcome in a very quick manner, or in an unaware manner, or in a way in which they that happens efficiently, so even when they're doing other things. So all of these features, all of these automaticity features can refer to implicit measures. So implicit measures can be defined as measurement outcomes that reflect the to-be-measured construct in an automatic manner, that is by virtue of processes that are uncontrolled, unintentional, goal-independent, purely stimulus-driven, autonomous, unconscious, efficient, or fast. Now some in the room might say that it doesn't make sense to say that all of these features can refer to automaticity. What is then the use of the concept automatic? But the point I want to make is that whenever you say that a measure is implicit, it can refer to these different features, and you can say that it's automatic or implicit in one of these ways. So, what interests you most probably is what are these measures good for? Now, many people, if you go in the literature, have the impression that implicit, if you use the word implicit, it means unconscious. Do not make that link. Implicit measures do not tell you something about unconscious cognition or something like that. If we look at the empirical evidence, we see that people are very aware of the things that an implicit measure captures. So they can, for example, tell you what an IIT is capturing, what you're doing with an IIT. There's even a recent study by Adam Hahn who shows that people can predict their own IIT scores, and that their prediction of IIT scores even predicts more behavior than their explicit ratings of something. So they can, in a sense, you don't have to do the IIT, you just have to ask people, what do you think will your IIT score be? So implicit measures and unconsciousness, forget about it, okay? Does it capture true beliefs, true representations? First of all, I never know what is a true representation. Is a true belief of something, is that what I say when I have the time to think about it, or is this my spontaneous belief? Which one is the most true? I don't know what criterion to use in that sense. But definitely, outcomes or implicit measures, so outcomes of these measurement procedures, are not stable or context independent. They are very context dependent. So it's not the case that I can go into a very stable core belief that I want to catch. If you want to do that, sorry, go ahead and continue your search, but implicit measures will not deliver them because they are very context dependent. Can they look into our early beliefs, the first beliefs that we learned? Yes, maybe, but definitely not always, because if I just tell you, for example, that Nephites is a new social group that you don't know, but that they are very bad, this one sentence is enough to produce a negative implicit score on an IIT, for example. So even immediate instructions, it's not necessarily early socialization, also very recent experiences can produce scores on implicit measures. So again, sorry, not that. So what can it do? I do think they are very useful, but they are useful for one thing, namely to predict the automatic impact of representations on behavior. And here we come basically to the realization that has been around for a long time, or at least since the 70s and 80s, and that's that people can behave in an automatic manner or in a more controlled manner. And so our beliefs and representations can influence our behavior in an automatic or in a more controlled manner. So if we look at people who are faced with a situation in which they have to take an airplane to go to a conference, that situation might automatically evoke beliefs about danger and that a crash might happen, and these automatic beliefs might also have an automatic impact on your behavior. Now, this is the route, the spontaneous route of behavior in which these automatically activated representations, spontaneously activated representations, can play a role. And this is the route that we can capture using implicit measures. Because what are implicit measures? Implicit measures basically are instances of behavior that is spontaneous, behavior in which spontaneous beliefs and representations influence your behavior. If you're in an IIT task, your outcome of the IIT task, with regard to fear for flying, for example, your outcome is a behavior that is influenced by your automatic spontaneous beliefs about the danger of airplanes. So implicit measures can allow you to capture this automatic route. So whenever behavior is spontaneous, implicit measures can add something, can allow you to capture this spontaneous route of behavior. So there is surplus value of implicit measures in predicting and understanding behavior that is based on spontaneous thoughts and feeling. This is the big use of the big usefulness of implicit measures. And there is good evidence to support this claim, because we see that the extent to which implicit measures can be used to predict behavior increase in people who show more spontaneous behavior. So people who do not have a high need for cognition, for example, their implicit measures will predict behavior more strongly than in people who do have a tendency to think a lot. Or in situations where you're loaded, where you're doing all kinds of other stuff, in those situations, implicit measures also predict your behavior more. So in situations where behavior is spontaneous, their implicit measures can allow you to predict more behavior than on the basis of other measures or explicit measures. So this brings us back to psychopathology, because psychopathology is, of course, an area where there is a lot of spontaneous behavior, or behavior at least that has features of uncontrollability or unintentionality. And there, I think implicit measures can allow you to capture these automatic routes of behavior that are less easy to capture with other measures. So, because pathological behavior and thinking is often automatic, implicit measures can be useful to capture those automatic behaviors and beliefs. There has been quite a bit of research already on the use of implicit measures within psychopathology. So there is a review paper in Psychological Bulletin by the group in Amsterdam and in Maastricht. There is a more recent paper in Clinical Psychology Review. I'm not going to review all of this evidence because I see that I still only have 5 minutes. Mainly, it's about there are differences between groups with regard to implicit measures. You can use implicit measures to predict clinically relevant behavior, and there are a few studies, but not that many, on whether therapy also leads to changes in spontaneous representations, spontaneous beliefs and thinking. But still there is a lot to be done. There's a recent study in which we, for example, were able to predict relapse in smokers who went through a smoking stop program, where we achieved a 72% prediction of relapse after 6 months. And that went up to 90% if we looked at people who have low attentional control. And this prediction was better than could be achieved also on the basis of clinical judgment. So there is space for the use of implicit measures to improve our prediction. It also sometimes generates interesting results that do not fit well with our current thinking. For example, in depression, we find that implicit self-evaluation, so your automatic beliefs about yourselves, even depressed people tend to have positive automatic beliefs about themselves, which is a strange finding that my colleagues and I in Ghent are now pursuing. But generally more research is needed. But it will not go away. That's one of the main messages I want to give and that I want to finish with. These implicit measures will not go away. For example, Daniel Kahneman's book about the two ways of thinking has made this idea very popular. You have automatic behavior, you have control behavior. There are many things to dislike about this book, but one thing it has done is that it has made people aware that there is automatic behavior, that we need to also capture changes in these automatic behavior if we really want to predict influence and understand behavior. So they will not go away. We also will never replace them with brain measures. You can have implicit brain measures. You can have implicit measures that involve brain responses, but also these measures need to be validated. You also need to assume that they are valid, that they capture the thing that you want to measure, and that the way that the construct influences your brain response is implicit. So you also need to validate them. And the one thing about implicit behavioral measures is that they are still more easy to apply than these potential brain measures, also via the internet. So you see, for example, my colleague here in Amsterdam, Bruno Verschuren, he's still not satisfied with any brain measures of lie detection, and he is still developing these behavioral implicit measures of lying. So I will not go into the future. If you want to hear more about the future, there's also a talk I will give on a new type of implicit measures, namely implicit measures of beliefs rather than associations. I will go into the difference on Saturday. So definitely there is still a lot that needs to be done, but I think it will not go away. Just to give a last very quick illustration, we did a study in which we did persuasion, basically gave smokers persuasive messages about smoking, so anti-smoking measures. If you give them a cognitive anti-smoking measure, you see that explicitly they will say, okay, smoking is bad, but their implicit attitudes towards smoking become even more positive if you give them cognitive anti-smoking messages. So this shows, I think, generally, we need to be aware that if we are doing something with people, whether this is therapy or another type of intervention, we do not just have to look at what does this do at the level of the control behavior, we also always have to look what does it do at the level of the automatic behavior. And the implicit measures can offer a way there. We are definitely not there yet, but it, in my opinion, will not go away, and it's always useful to put them in there also. That's it.
I'm going to talk about biological markers of the periphery, and after me, Cynthia Fu will talk about central nervous system markers. Now, why stress biomarkers? How does this work? Okay. Stress is certainly something that each and every one of us knows from everyday life, something that we experience more or less on a regular basis, some more than others. I'm coming back to that later. But the reason why I want to talk about stress biomarkers is because stress has been shown to be associated with negative health outcomes in many thousands of studies. And we know that stress can precipitate, exacerbate, and perpetuate both psychological and somatic symptoms, and ultimately leads to a huge economic burden on our healthcare systems. So the prevalent model that tries to explain how stress translates into negative health outcomes is the allostatic load model put forth by Bruce McEwen, shown here. At its core is stress. Stress, which is a perception, and which is ultimately processed at the central nervous system level. Stress can lead to behavioral responses. Some of them are adaptive, some of them are maladaptive, and to a huge variety of physiological responses. The cardiovascular system is activated, the hormonal systems are activated, the immune system can be activated, which is all normal, and we need this biological and psychological response and it has developed on an evolutionary basis. It makes sense that we actually show this. Normally, there are so-called allostatic processes at hand that make those increases, those activation processes in the body go back to baseline, so that adaptation can occur after the stressful stimulus has ceased. But there are some circumstances where those processes are working overtime, so to say, and as a consequence, the immune system is overactivated over a specific amount of time. The hormonal system is overactivated, secreting stress hormones. And Bruce McEwen is calling this state allostatic load. And he describes it as a wear and tear that is being exerted on the body, ultimately leading to illness. So, as I said, we know a lot about the association between stress and illness. There are many studies out there, but what we really don't know is what happens in between, another black box. There are these systems that I have already mentioned that are playing a crucial role in the association between stress and negative health outcomes, and that are playing a crucial role in the mechanisms that are actually translating the experience of stress into illness. Among these are genetic factors, immune system, the central nervous system, and the hormonal system. So in order to better understand what the underlying mechanisms are that translate stress into disease, I think it is crucial to study biological systems that are stress responsive, both in their basal and reactive activity, and also how those systems are changing due to specific interventions that are able to reduce stress. It is potentially possible to have myriads of different biomarkers in order to get at basal activity, reactivity, and changes due to interventions. But I have also only listed 3 of them. Cortisol for the activity of the hypothalamic pituitary adrenal axis, a very important stress hormone. Alpha amylase, which is a salivary enzyme that is thought to reflect activity of the autonomic nervous system. And then there are signals within the immune system called pro-inflammatory cytokines. I'm coming back to those later. When I wrote my abstract, I thought that I will have time to delve into all of these 3 systems and talk comprehensively about cortisol, amylase, and cytokines, but unfortunately I won't have the time, as I realized. So I'm going to focus in my talk on cortisol, salivary cortisol mostly. And I'd also love to talk about various illnesses, but that's not possible as well. So I'm going to focus on chronic fatigue, on which I have done some research on. Chronic fatigue is extremely prevalent. There are many patients suffering from chronic fatigue. I have brought here data from the US, about 2.2 million cases in the US. I'm sure there are similar numbers in other countries, but we don't have the data. Again, this is exerting a huge financial burden on healthcare systems. And despite virtually thousands of studies and decades of research, at this point we don't really know what the pathophysiological mechanisms are, what really causes chronic fatigue, or chronic fatigue syndrome, which is the most extreme form of suffering from chronic fatigue. We and others believe that stress might play an important role in these pathophysiological mechanisms, though. We have been able to study the role of stress in chronic fatigue in 2 huge population-based studies in the US. One was conducted in Wichita in Kansas, at the heart of the US, and the other one, the bigger one, was conducted in Georgia, with sites mostly in Atlanta and in Macon. And among many markers, also biomarkers that we were able to collect, We have looked at cortisol levels, and we were also interested in early life stress and chronic stress in adulthood. So in both studies, we were collecting information on early life stress using the childhood trauma questionnaire, which allows us to discern information on early life stress on 5 dimensions: emotional, physical, sexual abuse, and emotional, physical neglect. And as you can see in both studies, the mean scores are markedly higher in the CFS group than in the non-fatigued control group. I won't go into detail, but I hope that you can see the pattern just from this slide. And interestingly enough, although these were completely different samples, some of the means are identical. So in both studies, we were able to show that early life stress is markedly higher in CFS patients than it is in non-fatigue controls. And we have also seen that depending on the individual dimension, the risk for developing CFS later can be increased from 3 to 6-fold, depending on which early life stress has occurred in childhood. So I'm coming back to those data later. In adulthood, we have measured stress in the past 4 weeks, where you can see that CFS patients report much more stress than non-fatigue controls are, and CFS patients also report more life events that are perceived as negative during the past 12 months. We were in the first study, in the Wichita study, we were able to collect saliva samples. All the patients and all the controls were invited into a CDC clinic where they were staying overnight, and we were able to collect saliva over the course of the day 6 times, immediately after being awakened, and later on another 5 times. And what we were able to see was that the normal regular dynamics of cortisol secretion over the course of the day was intact in CFS. The straight line are the CFS patients, and then there is actually a third group, the group insufficient symptoms or fatigue group, which I'm not going to talk about now, but it is a group that is, when it comes to symptoms, between non-fatigued and chronically fatigued individuals. But in all 3 groups, the normal diurnal pattern is intact, except for this early morning concentration. As you can maybe see, the CFS patients have markedly lower cortisol concentrations right after awakening. And considering that cortisol usually is being used as an energizer, if you want, in order to get up and be ready for the day, more or less, then this is something that apparently the CFS patients are lacking. We were quite intrigued by this finding, and in the second study, in the Georgia study, we were looking at this time window a little bit more closely. And what we were able to see was that immediately after awakening, there weren't any differences, but later on, 30 minutes later and 60 minutes later, an attenuation of cortisol secretion occurred in those patients compared to non-fatigue controls. Thinking back of the early life stress data that I have just shown you, we were able to stratify the 2 groups into those who have experienced early life stress and those who didn't. And we were looking at the cortisol data in this group, and what we saw was that only the patients that have also suffered from early life stress were the ones that had these attenuated cortisol profiles early in the morning. Now these are basal activity patterns of the HbA axis. What we don't know is what happens when the system is actually being challenged, and we try to do that. We invited patients and controls into a clinic at Emory, and we exposed all our participants to a psychosocial stress test, the so-called TRIA social stress test, which basically consists of a mock job interview in front of a stern-looking audience. That's the first part, and the second part is mental arithmetics. It's a tough stressful procedure, and we know from many studies that it reliably evokes a stress response both on the psychological and physiological level. Now, this is what most people would show after cessation of the stress test. There is a steady increase of cortisol concentration over the course of about 20 to 30 minutes, and then there is going back to baseline. But the CFS patients, they were not able to mount a cortisol response similar to what we would have normally expected. So there is less cortisol reactivity, less reactivity of the HPA axis present in those patients. Now, what does this mean? Usually cortisol has an inhibitory effect on the immune system, particularly on so-called cytokines, which are signaling parameters within the immune system, with interleukin-6 being one of the most important pro-inflammatory cytokines, having a major role in inflammation processes. And we know from many studies that a dysregulation of IL-6 secretion has direct effects on central nervous system, with fatigue, increased fatigue, and increased pain sensitivity being one of the consequences. So we were looking at IL-6 in those patients, and we were particularly interested in this early morning phase when there is low cortisol. And what we found was that indeed IL-6 is much higher in CFS patients early in the morning than it is in non-fatigue control. So apparently there used to be a break, kind of a break in cortisol that is now lacking, and eventually leading to a steady increased activation of the immune system. It's not a big increase and it's not a huge activation, but it is sufficient apparently to produce the typical symptoms of chronic fatigue. We call it a chronic low-grade inflammation process that might be going on in these patients. Now, these are patients, they are severely fatigued, disabled, chronically fatigued. We were also interested in looking at non-patients, in people that are stressed on a normal basis, like you and I. These are students. We were equipping them with an iPod and asking them for 2 weeks in total about stress levels and fatigue levels, and we were also asking them to collect saliva samples themselves over the course of the study. 1 week was a control study midterm when they didn't have any exams to take, and the second week was a week towards the end of the term when they had a variety of exams to take, which we consider to be a stressful situation. That's exactly what we found. These are average levels of stress and fatigue. So during the exam period, students were more stressed, they were more fatigued. But interestingly enough, over the course of the day, we did not find any differences in cortisol. And opposite to what we found in chronic fatigue patients, the students showed increased cortisol in the morning. So apparently there is, this might be the normal cortisol response that we can expect from those people who are not severely fatigued and chronically stressed yet. Interestingly enough, we found that stress predicted fatigue levels, and the same was true the other way around. But that was not mediated by cortisol, although we hope that we would find such an association. But this is probably only true for patients that have chronic dysregulation of the HPA axis. So the big question is now whether those biological alterations are potentially irreversible, and I'm presenting 3 studies. 2 of them are pilot studies. This is the first one by Roberts and his colleagues. What they were able to show was in a small pilot study of CFS patients receiving CBT, which is the most effective intervention in chronic fatigue. They were able to measure cortisol secretion patterns over the course of the day prior to intervention and 6 months later after the intervention. And what they were able to show was that after the intervention, cortisol levels were increased a little bit. It's not a big difference, but when you look at the overall secretion of cortisol over the course of the day, then there is a significant increase between pre and post. So apparently, at least to some extent, and at least in this small pilot study, it seems to be that an adequate intervention is able to increase cortisol levels and to maybe reinstate normal HPA axis activation. In another study, the same authors were looking into those who responded well to CBT and compared the results to those who did not respond sufficiently to CBT. These are cortisol data prior to the intervention. So what you can see here is the straight line. Those are the patients who went on and did not benefit from CBT. They have significantly lower cortisol concentrations in the morning, so they are more severely affected, and they show a less dynamics in the HPA axis compared to those who eventually went on and were able to benefit from CBT. And the final study that I want to present to you is this one here in adolescent CFS patients. In this study, which had a big sample size, the authors were able to show that prior to treatment, compared to healthy control, the CFS patients had lower cortisol in the morning, which we call relative hypocortisolism, relative to the healthy controls. And they were also measuring cortisol profiles after treatment and found that those who were able to recover from the symptoms after successful treatment had slightly higher cortisol levels than those who did not recover. So these are first evidence that it is actually possible, if you have an adequate treatment strategy, to reverse those biological alterations that we have observed in chronic fatigue. Of course, CBT is a mixed bag of interventions, and ideally it is specifically tailored to the needs of the patients. But it would be interesting to see whether specifically stress-related intervention techniques would be even more helpful, at least in those who also suffer from chronic stress, and that's what we are trying at the moment in a trial that we are undertaking. It is interesting to see, on the one hand, peripheral measures as outcome measures and see whether they can be changed, but on the other hand, it would also be extremely interesting to look at underlying mechanisms, and this is a very exciting new area where we are also trying to work in the underlying gene expression that might explain why some people show altered endocrine concentrations. So we were able, for example, to show that specific genes are activated under acute stress. Other groups were able to show that there are patterns of genes, mostly stress-related, immune system-related, that are particularly active in those people who are perceiving chronic stress. And we are asking now ourselves in the study design that I have just shown you, whether there is maybe a characteristic stress signature in those gene expression patterns. Maybe there is one that is specific for those who suffer from chronic fatigue. And of course, it would be extremely interesting and fascinating to see whether those patterns are actually subject to change after an adequate tailored intervention, and whether those changes would also be predictive of intervention success. So in order to get at those answers, in order to get at underlying mechanisms that translate stress into illness, it is extremely important to take a multidimensional approach, to not only ask people about their symptoms, but also to get at information from various levels. We are going to hear about the central nervous system in a minute, but it is also important to get information from the immune system, from the hormonal system, and underlying gene expression patterns. So I hope that I have been able to show you that the stress is an extremely important factor in the development and manifestation of a variety of illnesses. I have specifically focused on chronic fatigue. I hope that I have been able to show you that it is important to take a multidimensional approach. Also, I have mainly focused on cortisol, but this is not happening in itself. It's happening within a system with many, many other players that have a role. And I hope that I have been able to show you that there is at least some emerging, promising research that shows that some of these alterations are being subject to intervention and can actually be made reversible. But much, much more work is being needed when it comes to the underlying mechanisms, and we are only starting to begin to understand what are the driving mechanisms behind those biological alterations that I have presented to you. With that, I'd like to thank the people that have been involved in the work that I have presented, and the funding agencies, and of course you for your attention. Thank you very much.
So I'm going to talk a bit about some of the work that we've been doing in brain imaging to look at the regions affected by depression and how they change with treatment. In this case, I'm going to be focusing on CBT treatment, but we've also done work looking at antidepressant medication. And then from this, going to talk about how we can develop potential biomarkers to diagnose depression and even to predict response. So I think we're all familiar about the mechanisms of cognitive therapy, and I'll just review it briefly. A key mechanism is that cognitive therapy is proposed to improve cognitive control, top-down cognitive control, and in this way it increases the inhibiting role of executive function, and in particular there's some suggestion that it may have a particular effect on negative affective cognitive control. And in this way it improves the underlying dysfunctional attitudes, okay? The dysfunctional negative schema. In contrast, antidepressant medication has been proposed to have more of a bottom-up effect, in which it improves the negative affective bias by targeting the limbic regions. For example, we found that the selective that SSRIs such as fluoxetine, which is also called Prozac, inhibits amygdala activity. But there is also some evidence that it can have some early effects on negative biases, okay? And we've been looking at these mechanisms in a variety of tasks designed to target each of the mechanisms. For cognitive control, we've used the emotional Stroop task. For dysfunctional negative schemas, we've used the dysfunctional attitudes task. And to look at the negative affective bias, we focused on affective faces. And we've done this with both cognitive therapy and antidepressant medication. Okay, this is one of our first studies where we looked at implicit processing. I think there's what fits in the definition of implicit processing, but you can correct me. We've been looking at how people with depression process negative sad faces. And we showed them different intensities of sad faces, low, medium, and high intensity. And what people had to do was decide on the gender of the face, whether the face was male or female, so that the emotional processing is done implicitly. Okay, so they're not actually deciding on the affect of the face, but they're deciding on the gender. And as you know, face processing involves quite a number of regions, and we're going to focus on the amygdala, on the emotional processing. I do have some colleagues who will be presenting on face processing on Saturday, so you're welcome to go to their talk on Saturday, their symposium on Saturday. So in particular, we're focusing on the amygdala, and the amygdala response is the center of the brain that responds to, hey, wow, what's going on, okay? In particular, fear. But it also has a high response to emotions of happiness, and what we want to focus on was sadness, okay? How the amygdala responds to sadness in people with depression. And what we found was that when people were acutely depressed, they had increased activity in the amygdala, which resolved following treatment with, this case with fluoxetine, after 8 weeks of treatment with fluoxetine. Okay, so it normalized to the same level as people as healthy controls. And as well, the anterior cingulate activation at baseline before they received any treatment was correlated with how well they subsequently responded to treatment. In the same group of people, we showed them happy faces, and in this case, we found that this region called the striatum showed less activation when they were acutely depressed. That the striatum was related to happiness and activity, and it resolved following treatment with Prozac, with fluoxetine. So in a different group, we use the same paradigm. Okay, we show people sad faces, implicit processing of sad faces, when they were acutely depressed and following 16 weeks of cognitive therapy. They were all expert therapists, so they did show most of the patients responded to the therapy. And what we found was that when people were acutely depressed, they had increased activity in the amygdala, which increased activity when they're acutely depressed, which normalized following 16 weeks of treatment with CBT. So this was the same pattern of response as in another group who had treatment with fluoxetine, with an antidepressant medication. And again, the anterior cingulate response at baseline predicted how well they went on to respond to treatment. In particular, this was the intensity of facial expression: sad, low, medium, and high. These are healthy controls, okay? And these are the responders, people who responded to treatment. I want to point out that people who did not respond to treatment, they had quite a different pattern of response to the intensity of faces before they received any treatment. I think this fits a bit with what Wolfgang has presented. This is a different group. It'd be interesting to see. And also we looked at cortisol in this group as well. So it'd be interesting to see how this all works together. So this was affective faces. We're looking at the basic perceptual affective bias. And then we look at cognitive control. We'd use the emotional Stroop task. You're probably all familiar with emotional Stroop task? All familiar with the Stroop task? Okay. So in this case, you would say, this is in Dutch. That's in case you don't know. So you would say, right, okay. And in this case, what would you say in Dutch? Grunt. Okay. I looked that up actually. And in this case, blauw, right? And in this case, this is okay. In English, this is friendly. Okay. And in this case, groan. All right. People with depression are slower, okay, when it comes to a negative emotional word. They're slower to respond. And what we found with the emotional Stroop is that the amygdala activity, when they were acutely depressed, was increased. And following 16 weeks of treatment with cognitive behavior therapy, their amygdala response normalized to the same level as healthy controls. Okay, so people with depression are responding to this emotional Stroop task, and again, activity in the anterior cingulate correlated with treatment response. We are writing up data right now with a different form of treatment, with an antidepressant treatment medication. And this pattern of response is different from an antidepressant medication. So with the emotional Stroop, we've focused on cognitive control. We found differential response in the amygdala and in the anterior cingulate. And then from this, we want to look at dysfunctional attitudes, okay? How do we look at the dysfunctional negative schemas underlying depression? And in this case, we use the dysfunctional attitudes scale, which you're all familiar with. Okay, this isn't an implicit task, so people did rate their attitudes. And we use a control task in the scanner. We created a control task in order to balance, in order to control for their type of attributions, as you know, whether it's extreme or regular attributions. So I'm showing you the results of the dysfunctional attitudes scale itself. And people with depression, when they're acutely depressed, they do show more extreme attributions on the dysfunctional attitude scale, as would be expected. Okay, and this is different from the regular attributions. And following treatment, there was a reduction in their endorsement of extreme attributions. And this was different from the attributions to the control dysfunction, to the control task. So we did elicit a significant difference. And in the brain, this is associated with a significant interaction in the parahippocampal gyrus. So people, when they were acutely depressed, they had similar activity in the parahippocampal gyrus as compared to healthy controls. But healthy controls, their activity reduced with time, whereas people with depression, their activity stayed kind of the same. All right, so they're still processing, even though their extreme attributions were reduced, they're still processing this. They're still having residual contextual processing with dysfunctional attitudes, which might have implications for future episodes. Because as you know, most people with depression, they do tend to go on to have subsequent episodes. So we've been looking at each level of the effect of cognitive therapy in comparison with antidepressant medication. And this is a meta-analysis that we performed to look at how it compares to pharmacological treatments, to pharmacological therapies. Briefly, there are a lot more pharmacological studies looking at pharmacological therapies with neuroimaging than there are looking at cognitive therapy, so a lot more research needs to be done. These regions, you only come out with a handful of regions because there are so few studies as compared to antidepressant medications. And then from this work, we've been looking at, well, can we use neuroimaging to help to diagnose depression? Can neuroimaging be used to predict clinical response? And this is a summary of all the regions, of some of the regions in terms of predicting clinical response. And this region, the anterior cingulate, is coming out again and again. And we performed a meta-analysis. And I'm just highlighting again how few, the ones in orange, how few studies there have been looking at cognitive therapy, looking at talking therapies, looking at pre and post changes, neuroimaging changes with talking therapies. And what we found is that this region in the anterior cingulate is predictive of response, okay, whether it is psychotherapy or antidepressant medication. There's also a region in the insula which is predictive of response. But the literature for talking therapies is much more mixed. Some studies suggest that there's increased activity in the anterior cingulate, and some studies suggest that it's reduced activity. So again, we need more research in the area. So from this, we want to look at, well, can we develop a biomarker? Well, first of all, what is a biomarker? Biomarker is a characteristic that is objectively measured and evaluated as an indicator of normal biological processes, pathogenic processes, or pharmacological responses to a therapeutic intervention. And the problem with brain imaging research is that if your person is here, your subject is here, you don't know if they belong to the healthy group or, in this case, to the depressed group. Okay? This is just to show it again. So if this is your range of responses for healthy individuals, this is your range of responses for people with depression. If someone's in there, you don't know if they belong to one group or the other group. Now, instead of looking at the mean of responses or the mode, you look at the margin of differences. Okay, so if you look at the margin that separates the two groups, okay, then you can define a margin, in this case a linear margin that separates the two groups, so that if you have it, and then you can use mathematical formulations to find the best margin. In this case, we use support vector machine. So that if you have a new subject, you can determine whether they belong in the healthy group or in the depressed group, in this case here. Okay? So we use this technique with our neuroimaging data. When we started, this was we got quite a lot of criticism because most of it has been done, a lot of skepticism, because it had been done previously in healthy individuals with different states, okay? So looking at different states in the same person. In this case, we're looking at the same stimuli in different people, and there was a lot of controversy about whether or not it would be possible. This is just an illustration, say. If these are numbers, 3, 4, 5, 6, 7, 8, and this is a pattern. So if you're shown a new pattern, you can guess what it is. You can estimate quite accurately what it is. However, when you have brains, if this is group A, group B, if you're presented with a new subject, it's more difficult because of the pattern of distribution. So using machine learning, in this case, support vector machine, we found that at the individual level, there was high sensitivity and specificity for predicting response based on the pattern of brain activations to sad faces, all right? So this is before people had received treatment. Even before they had treatment, we could tell with reasonable high accuracy whether that person would or would not respond to CBT. Okay. This is different from antidepressant medication. In this case, it was fluoxetine. In this case, it was brain structure that predicted response. Okay? It was the brain structure that predicted response to antidepressant medication treatment, whereas brain function predicted response to cognitive therapy. And this is to show that we also looked at diagnosis, and the regions associated with diagnosis are different than the regions associated with the regions that identify whether someone or not has depression are different from the regions that predict whether or not that person with depression will respond to treatment. Okay, so it's a different patterns. And this research has gained a lot of press. Now, what I would suggest whenever you read these headlines is to look at the data and see, are these group level differences? Because a lot of research is group level differences, or is this at the individual level? And that's what's important. If it's important for your patient who you're seeing, your client who you're seeing, whether or not you can predict response, okay, or whether or not they have whether their depression shows biological markers that may be the reason I'm having trouble with this is because it's an iterative process. I'm not saying that if the person in front of you has depression, they're presenting with depression or chronic fatigue syndrome, but not everybody who presents with the illness, with the clinical manifestations of the illness, will have a biological marker, okay? Because all of our diagnoses right now are based on clinical signs and symptoms, right? So we wouldn't expect that everyone who presents would have the biological marker, and so it will be an iterative process. Okay. And that's it, but I'd like to thank my colleagues, and I'd like to thank the MSc students, Angeli, Martina, and Nick, who did a lot, and Adrian, who's an MSc student, who helped collect the data, Robin Murray, who sponsored, the head of the Institute of Psychiatry, Tony, who helped with the cortisol data. We do have cortisol data on this group. Vincent, Janina, Steve, the neuroimaging, John and Ed, the neuroimaging analysis and the collection. Jan, who helped with the dysfunctional attitude scale, and also the machine learning experts at the Royal Holloway, and our CBT therapists. Okay, thanks very much.
So just to go back to the basics, why assess change in the first place? There are a lot of different things, reasons that we've heard about this morning. Particularly, the first thing, obviously, measuring outcomes, looking at changes in target variables such as symptoms. But then we get on to more interesting questions like, what are the most appropriate types of outcome to be focusing on? How they link to risk factors like early life stress that we've heard about. What therapy does best and what works for whom. Secondly, we can focus on the context. How does this context influence the effectiveness of therapy? So, for example, from Wolfgang Lutz, we were considering the context in terms of what the therapist is doing, how the therapist is responding and seeking information that will help to change the course of what they're doing and their attitudes towards that. Also, Jan de Hoover mentioned another contextual variable, which is cognitive load. Many of our patients will be under huge cognitive loads from all the social stresses that are present in their current environment, which will be having a massive impact for some of them on things like working memory capacity, on their ability to respond to us as therapists. And then also measuring process. So measuring changes in the psychological and biological correlates been mentioned by Urs Nata and Cynthia Fu. So what is their relationship to outcome? But also we can look at prognosis, treatment response, as well as diagnosis. And think in more depth really about when and how change might occur. So before moving on, just to consider this question of what outcomes should we actually be measuring? This isn't a straightforward question. And we think we shouldn't be over-relying on symptoms too much as outcome measures. But for example, changes in positive affect may turn out to be as or more important, or improvements in relationships. And particularly when we consider conditions such as abnormal or prolonged grief reactions. Clinically, we know that we're not going to get massive differences or changes in sadness, but we are going to shift people from a sort of being stuck in a very ruminative process back to a sort of more normal way of evaluating their sadness and the losses that they've been through. So we may not see huge differences in symptom measures, but we may see some very significant and important changes in positive affect, interpersonal functioning, and other outcomes. Increases in activity and social engagement, for example, may be hugely important outcomes for certain groups of people. So I'd like to, in the next slide, think a little bit about how change happens in psychological therapy and the clues that are there that might sort of direct us in positive to fruitful lines of inquiry. Particularly the fact that sudden and substantial between-session gains are often observed in therapy. And Wolfgang Lutz also referred to this, for example, the rapid responders would be one example of people showing big changes. But these big changes can also occur at lots of different points over the course of therapy. And they seem to be important because these people who have these big positive changes during the course of therapy, not just at the beginning, but also later, have better outcomes. So this is a clue that we should be investigating these processes in much more depth. And we need theoretical models that can give us a handle on what's going on with people who respond gradually over the course of therapy versus those who respond very quickly. And one sort of theoretical approach that's impressed me in this is complementary learning systems theory, first introduced by James McClelland and his colleagues in 1995, based on simulated learning by neural networks. Now, this doesn't sound like neural networks have a lot to do with the depressed people sitting in front of us, but they're very fascinating observations made from studying neural networks. And whereas in the beginning, these networks were trained to learn concepts, for example, like that birds were creatures that could fly. And what James McClelland and his colleagues pointed out was that these networks perform terribly well until you introduce contradictory information, until you present the wretched network with the example of a penguin and say, well, this is a bird, but it can't fly. And this leads the network to exhibit what is called catastrophic interference. And we can feel sympathy for the network. It's just we feel sympathy for our patients who are confronted with information that totally contradicts everything that they thought they knew before, because traumatic events are characterized by presenting us with things that contradict everything we thought we knew about ourselves, the world, and what makes things happen. And of course, our patients respond very much like these neural networks. The catastrophic interference seems to be a very good simile or metaphor, if you like, for people faced with information that they cannot take on board and comprehend. And it also emphasizes how people can know things at different levels. So McLennan and his colleagues suggested that in addition to a sort of neocortical learning systems which make slow adjustments to the, and gradually develop certain concepts that account for all the data in a very complete way, we also need a fast hippocampal learning system in parallel, so that information may be represented within one of these learning systems, but not in the other, generating things like our patients tell us about how they know something at a cognitive level is true, and yet they can't actually feel that it's true. Actually, the opposite seems to be true to them if they attend to their sort of emotional reactions to something. So originally, this neocortical learning system was thought to integrate data in very complex ways, but to take quite a long time to do that. Whereas, and in contrast, the hippocampal learning system requires conscious attention, and it's flexible, but it's very capacity limited. So these sort of notions of two learning systems which can learn at different rates, we can apply these ideas and think, well, could they help us to give us insights into what might be happening in our patients who are responding quickly or slowly to the therapeutic process? And we might think of other possible rapid learning systems, such as image-based memory systems that could respond very rapidly, much more rapidly than conceptual or verbal systems. So if we think about what our therapies do, okay, let me go on to the next one. A lot of our therapies we can think of as representing these sort of slow learning processes, these neocortical systems described within complementary learning systems theory, which involves a corrective input, like cognitive restructuring or familiarizing our patients with dissociated contents that addresses what has been avoided. And it's generally a sort of quite a slow, repetitive process. You have to go over things a number of times, and you very gradually see that the person is learning from this, and they're gradually applying their knowledge in new situations. But it's something that takes quite a long time. But we think that this sort of slow cognitive process gradually leads to the emergence of new or different cognitive structures that perhaps can then become stable in their own right and compare and compete with the existing negative self schemas when our patients are confronted with stressful situations or ones that are likely to provoke emotional reactions in them. So I think behavior therapy and cognitive therapy, because they both emphasize a great deal of practice, repetition, very much exploiting these slow learning processes. But now we can also should be thinking about therapy as fast learning. And in particular, this notion of insight. So how can we think about insight? Well, McLennan has now suggested that actually these slow neocortical learning mechanisms can actually operate pretty niftily when they come across some information that is actually consistent with what they already know. So that suggests that maybe what we call insight is that people are able to be given ideas showing that something they thought was totally inconsistent is actually consistent with other of their previous well-learned knowledge and beliefs. So it's perhaps a different perspective on the information that's presented with them, which actually is consistent with lots of prior learning and which will enable rapid change to take place in their evaluation and appraisal of their current situation. We can also exploit the brain's capacity for rapid learning using techniques like imagery rescripting. And we know that we can combine in visuospatial working memory negative images from the past and new positive contents. we can simply ask people to attend to negative images that spontaneously come into their mind and introduce new positive elements which give those images a completely new meaning. So we can ask a woman who has intrusive images about a very violent partner, for example, to imagine that person shrunk down until they're only 9 inches high, running around on their kitchen floor, being chased by the cat. Now, this can lead to extremely rapid therapeutic change. You know, within a matter of 20 minutes or something, someone can change from having an intimidating, terrifying, overwhelming negative image into a positive competitor image, which is fun to think about, which makes them smile, makes them feel confident, makes them feel curious about their own sort of mental processes and their ability to change their internal life. So here is another example of fast learning, and as therapists, we desperately need more fast learning methods and techniques. And we need to understand how the kind of early learning experiences we've heard about, how these different biological and psychological processes may enable some people to use these fast learning techniques. They may give us clues about what these different learning mechanisms are based on, who may be where, and the situations and contexts in which we may be able to exploit methods of helping people rapidly rather than helping people slowly. We're quite good at helping people slowly. It doesn't work, it works a reasonable amount of the time. But think how much better things would be if we could speed up this whole process and get as many people as possible into fast learning mechanisms. And that, which probably, again, given the evidence in front of us, suggests that the people who are going to have the best long-term outcomes. So, just to conclude, randomized controlled trials of treatment packages have been very helpful in establishing proof of efficacy. But in many ways, I think a lot of these RCTs are very premature in terms of our understanding of how the treatments work. We've got hundreds of partially effective treatments, but very few that really produce large amounts of change in a clearly defined target group. We need better and more comprehensive assessments of outcomes, contexts, and processes, which will hold the key to a really proper understanding of how change occurs and how we can exploit the different options that are open to us. So our measures are still really quite limited. Context remains largely ignored, particularly the influence of the therapist and what they do. These opportunities for process research, I think, are very exciting and bring together a variety of the sort of cognitive and biological variables that we've heard about this morning. And I think to maximize these gains, we're probably going to have to get away from a diagnostic level of defining our patients and moving towards a level of looking at specific transdiagnostic processes. And these would include things like neural and hormonal stress responses, automatic and control processes that can be specified and measured much more exactly than our current diagnoses. So at that point, I'll finish and hand over to the rest of the speakers.
A surprise about in depression finding like positive schemas and positive aspects. And in our research, we have found in depressive patients both, of course, negative views of self, negative schemas, but also positive schemas. And what it has been fascinating is to find that maybe a key factor is a conflicting relationship between those. So in assessing change in schemas and dysfunctional attitudes, we are always looking at negative schemas. But these are absolutely essential. But also there is a conflicting relationship. So sometimes changing a negative self-schema involves a change in a positive self-schema. And that refrains people from change. In doing content analysis of their personal constructions, we have found in depressive patients, they value themselves a lot, on moral issues. For example, they think they are good people, morally, sensible, human, but maybe they are not competent, maybe they are not socially or other things. So sometimes changing in a negative self-schema in some competence aspect or being lovable, it would imply also a change in a positive thing, that they remain as good, as being human or sensible or good people. And these kinds of aspects have not been much tapped. But we find in several research, like the one you mentioned, little evidence from time to time it's increasing that there is also positive construction about themselves. And this has been overlooked, I think, in the literature.
I agree. Not sure whether this microphone or this, probably. Yeah. So it's definitely the case, and one of the shortcomings of the measures that we have until now is that they just focus on I and good. But there are many ways in which I and good can be related. I can be good in this, not in that. I am good, but I am bad maybe at the moment, or not competent, but I want to be good. So there is the measures that we are using at the moment are gloss over all of these differences, but there are new measures coming about, which I will talk about on Saturday also, that can target more specific beliefs. So together with Rudy de Raad, we are doing studies now in Ghent, trying to target different types of beliefs. And there you indeed see that sometimes I goes together with good, but then maybe in the sense of I want to be good rather than I am bad. So also the things that you mentioned, that I'm a good person, also those beliefs in principle we can measure at an automatic level. And this is something we still need to do. I agree.
I just wanted to add that we have a symposium on conflict in meaning systems and ways to measure this type of conflict later this morning.
Okay, while you're thinking about your next question, I want to pose my own question to the panel. Chris, you mentioned in your integrative comments that there was a lot of, or our common denominator for assessing treatment outcome is symptoms, clearly. And I wanted to ask all the speakers, if you had to select your dream team, okay, of outcomes, of possible outcomes that you would like to assess in terms, and they're not limited to either symptoms or functioning, but they could be processes or reactivity and so on. What would that be, if you would like to comment on that?
Me to start?
Yep.
Yeah, I think on a very broad level, talking about outcome measures, this came up a couple of times. I think the most common sense is probably on symptoms in a way, and on a broad sense, we are able to track, I think, progress from like a general psychopathological point of view, the outcome. And so it's more difficult if you measure like just anxiety, just depression. There's lots of overlap with the different disorder-specific measures. But coming back to your question is, I would say like the symptoms part in a broad sense is necessary, especially if you wanna cover the progress transdiagnostic, not just for one different disorder. And then I think interpersonal problems, this was mentioned a couple of times, that makes a lot of sense. Also on an outcome level, there's kind of an older theory, like the phase model of therapeutic change, where there have been like items which change faster than others, which goes back to more well-being oriented items. They change faster, tend to change faster. Then there's more the symptom-oriented items. They change a little bit slower, and then interpersonal functioning or general functioning items, they change even less fast than the two other categories. So that would be on the outcome side, but when we come to the process side, it tends to be using also like more the technique side and then the alliance side. So that's basically on a very broad scope, I think, necessary to measure. I think the biological side will come more from others, yeah.
Well, when we've looked at predicting response, we focused on the Hamilton rating score for depression. And we've also collected the Beck depression. They are correlated, but they're not exactly the same, as you know. So more recently, we've been collecting disability measures. So that'd be really interesting, actually, to look at whether they are correlated. Okay, most of the people whose depression scores, based on the Hamilton, their BDI scores also improve, and their disability improves, but it's not exact. So it'd be quite interesting to look at whether there are different biological predictors especially for disability, because that affects whether people are able to return to work or go to school. And also, I'd be quite keen to look at therapeutic alliance as well to see how that influences their changes. So it's quite important question how you measure outcome, right? Which one you use, yeah, because it affects the results.
I do not do this type of psychological change myself in terms of psychotherapy, for example. But I think what I think might be necessary here are the difficult studies, the big studies where we really look at change over time, do many measurements over time with regard to different levels, not just self-report, behavioral, the neural, the physiological thing. And then there are now ways to deal with these large data. So if we could put them together into network models where we see how connections between different types of measures evolve also over time. These are the big difficult studies, but they will probably learn us more than when we continue to focus in smaller studies on different types of changes. So as I think one of your aims of the symposium is, there needs to be more of an integration here between the different types of studying. We have a good idea of what types of behavior are important, what the different classes of what is interesting to look at. Now let's put them together in big studies over a period of time, use new ways to look at patterns in the data. And that, I think, could help us ahead.
Most of the things have already been said. I can only echo what has already been said. The easy way would be to measure all of them, everything. And I actually see that in some big trials when officially there is just one or two outcome measures, but unofficially people measure tons of markers, both biomarkers and psychological markers as outcome measures, and then go on and try to data mine whatever they are interested in. And I think that's one possibility. One can do that and do apply network analysis. And I'm pretty sure that this can be very helpful. But the one thing that I think would be really important, and that would be to really derive from theory, from concepts, what are the markers of change, and really have an understanding, at least a theoretical understanding of what it is that drives pathology and pathophysiology, so that you really know what it is that happened when you look at an outcome measure. So it's probably not everything, but it should be theoretically derived, a set of markers on various levels, probably. And I think that the transdiagnostic approach that has been mentioned now several times is probably the one that will provide us with the best information, going away from specific diagnosis which are on the self-report level, more towards a processes level, as it has initially been intended by the American Psychiatric Association when they put together DSM, and they back then thought that we are near a time when we can define illnesses based on pathophysiological processes and not on strict diagnostic criteria, but we're far away from that. But I think it's still kind of a hope that we are getting there.
Yes, as a practicing clinician, I think that what are the things that I notice and I think, oh, this person's really getting better? Sleep, one of them, and the other one is they're initiating some kind of new activity. So those are the signs that really impress me, and yet we hardly ever measure them in our RCTs, and I think maybe they've got quite a lot to tell us.
Okay, more questions from the audience? Okay, so I guess I would like to really thank you for thought-provoking and integrative, multidimensional light shedding on problems of therapy and psychopathology, and to wish everybody great remaining of the conference. Thank you very much.